Well, Anna's asked me to talk about optical recognition techniques, and you have heard now already that there is DALK techniques for keratoconus, and I would like to introduce a technique which normally is not so known because not everybody is doing it, but that's why it might be a little bit interesting to know about it. And I will introduce bowman layer inlay transplantation because this technique is used for this as well. So I cannot advance my slides, I just realized. Okay, I see it, I do it like this, okay. These are our financial disclosures. And when we talk about the optical interface, it's important to know that you have to find two effects because normally there is just a little refractive error between the aqueous and the cornea, and then you don't see actually anything. But if you inject air into the anterior chamber, you create like a mirror effect, because you will see two interfaces then. You will see an interface then that is created by this, and you have the instrument that you put on your cornea, and then you have at the posterior part the reflection of this interface. But you have to note that for the manual DALK technique, it's important to know that the half distance between the first and the second image is your corneal thickness. The second effect I would like to introduce to you is the dark band. This is an indentation effect because through this air bubble that you have in the anterior chamber, you can see this dark band from your instrument to the posterior surface, to the endothelium. And the thinner this dark band becomes, the nearer you become to the endothelium or the descemet membrane, and then you know which depth you are. So if we look at this intraoperative image, you can see here is the dark band a little bit thicker, becomes thinner, and here you're almost at the descemet membrane. To go to the manual DALK technique, you create a scleral tunnel, you fill the anterior chamber with air. We use those instruments to dissect, and here you can see this image, like first you find your depth, you go to the descemet membrane as near as possible, and then you take your second instrument with which you just do a proximal dissection of the superior part, and then you take the second instrument and do the entire dissection over 360 degrees of the cornea. And I have a little video for you to share. This is for a patient receiving DALK, and here you see the scleral tunnel. And after that, you fill the anterior chamber with air after doing a paracentesis. And then with this instrument, you find your dissection depth. So you carefully look at the reflection around this instrument, and then I will move it a bit quicker. So you take your second instrument in a second here, and then you start dissecting the same plane. So first you advance, and then you dissect on the same plane. You keep rinsing so that you don't have too much blood in the interface. And here you see you already used the third instrument to do the dissection over 360 degrees. And as you know from DALK technique, now you have to do the trephination. So first you remove a little bit of air, you leave a little bit of air to keep control. Then you put in the dissected pocket the visco elastic, and then you can trephine. And I will move that on because you know this step, of course. And what is now the idea? So for keratoconus, we know there was always penetrating keratoplasty as a good option to treat keratoconic patient where we have a good result, mainly compared to other indications. And we know that with DALK, we have even better option for patients with keratoconus due to the preservation of the endothelium. But actually, in 2010, Gerrit Melles introduced this intrastromal implantation of the bowman layer. And the idea was because actually you know that there are different treatment options for keratoconus, and you just heard cross-linking as an option to halt progression in those eyes. We had the problem that you had to keep patients advancing to getting a PK or a DALK. That means if a patient had progression but a too thin cornea, then it was impossible to do cross-linking at those earlier times. So that's why Gerrit Melles invented the bowman layer technique as an alternative for those patients to postpone the more invasive treatment with PK, for instance, and DALK. So this was the niche of patients that had no treatment because they actually were seeing still quite well with scleral lenses or contact lenses, but they were still advancing, but too thin, as I just said to you. So those were the target. This was the target group, patients with high Kmax, thin corneas, but still good vision. And therefore, we thought this could be a good option to halt progression. Because, of course, you know, even though the prognosis in patients with keratoconus is quite well, we still have patients where we have some kind of complications. And the idea was, why a bowman layer? We know that in keratoconic patients, we have the bowman layer or the bowman layer being sick. So therefore, we thought maybe by transplanting this layer, again, we would stabilize the keratoconus. And since it is an acellular layer, you have like in DALK, no risk for rejection. Here you see the preparation of the bowman layer. This we do in the eye bank in Rotterdam, where you create this thin roll, just like you see in DMAC, for instance. It takes a little while to prepare this, but if you have an experienced technician, then you are able to achieve this. And here you see the surgical technique. It simply looks the same like with the DALK technique. The only difference is that you are dissecting a different depth. So as I said, in DALK, you try to achieve as far as possible the depth near the descemet membrane, whereas in this technique, we aim at the 50% depth of the cornea. And as you see in the video I've just shown you, this is dissection, and then you practically, after staining the bowman layer, you inject it into this pocket and unfold it. I will show it to you shortly in a video because there is a little bit of time left. So here you see the scleral pocket. First, you create the sclerocorneal tunnel, then you do a paracentesis, you inject air. And after you inject the air, you start with the dissection. You first aim at the 50% depth. Then you dissect the proximal part, so it's just the same. And those, as I said, those optical phenomenon, they help you in finding the depth. And here you do the inferior part, and now I show you how, because now you reduce the air and now you put the glide into this pocket. Before you decellularize the bowman layer with alcohol, and then you stain it with trypan blue. And here you see how the bowman layer is injected into the pocket. And then this step takes quite some time, so you have to be patient here to unfold it by fluid and mechanically with your instruments to finally get, I show you the final position. So this is how you try to unfold it. You always monitor the air bubble in your anterior chamber. You know, these are young patients that are phakic, so you want to make sure you don't damage anything. And in the end, you have this situation. Well, then surgery is finished, and usually you can see with the OCT the bowman layer here in midstromally, and usually we see a flattening of the cornea, about 7 to 8 diopters, and the cornea thickens, of course, a little bit. Important, you have to know visual acuity remains stable in those eyes, so you should tell the patient that vision is the same, and that's why those patients should always have a good vision before you start surgery, because there is no improvement after that. So these are the main targets for dissection techniques. You can either get a DALK or you can get a bowman layer transplant. And the positive things about it is that it's a controlled technique, and bowman layer, even you have an uncompromised anterior surface of the cornea. You have no rejection. It's efficient use because you can use the bowman layer and you can use a DMAC graft for another surgery, and you may possibly postpone more invasive treatment. And with this, I want to thank you